What I'm going to talk about today is a little bit different than most of my other talks. It's going to be about sham peer review and innovation. And we all pretty much know in this room that sham peer review is a real tragedy for individual physicians and their families, but it's also a tragedy for patients who are deprived of the care provided by good physicians. And what you may not be thinking about is sham peer review can also be a tragedy for the advancement of medicine and science. When innovation suffers, so do patients. So innovation has both risks and benefits. It's the way we move forward in medicine to discover new treatments and cures. And the risks of innovation include sham peer review. There may be jealous competitors who resent the fact that the innovator can do things that they cannot do, and they may act on that jealousy and destroy the medical career of the innovator by abusing the peer review process. Innovators who were not treated well by colleagues at the time, but later were proven to be right, were doctors like Dr. Ignaz Semmelweis and Drs. Michelle Morawski and Dr. Morton Mower. And I'll go through the Semmelweis story. You all probably know it, just briefly. Dr. Semmelweis was a Hungarian OBGYN practicing in Vienna in the 1800s. And he was very astute. He noticed that when the physicians were going from the autopsy table to delivering babies, they had no gloves in those days, so it was all bare hands. When they did that, the mortality rate was pretty darn high. And so puerperal sepsis, the mortality rate in those days was about 25 to 30%. So childbirth was a big risk. And he suggested that maybe, he was thinking maybe, these physicians who are going directly from the autopsy table to the delivery room were carrying some agent that was causing these women to die. He was right, of course, but his colleagues at the time were very indignant that he would even suggest that their holy hands were carrying something bad that was killing these mothers. So they kind of had their own sort of a peer review type thing without any due process. And in those days, they referred him to what today would be considered a physician's health program, a PhD, which was an insane asylum. And they tricked him into going there. And of course, he ended up there. And the treatment in those days for that type of thing, the practice guideline of the day was cold water dousing, force-feeding laxatives, and of course, beatings. In those days, they thought maybe you could beat the craziness out of some of these folks. And so they did. They beat poor Dr. Semmelweis. And he suffered a wound on his hand while defending himself from one of these beatings. It got infected. And he developed gangrene and died at age 47 after being in that insane asylum only 2 weeks. These two doctors may not be as well known to you, Dr. Michelle Morawski and Dr. Morton Mower. In 1969, working in the basement of Baltimore Sinai Hospital to develop an implantable cardioverter defibrillator device, an ICD, a consensus-based peer review was conducted without any due process, and they were labeled as crazy. Some referred to their ICD concept as dangerous and speculated it would electrocute people. The experts scoffed at the idea, and medical elites did their best to discredit them. The ICD concept was soundly rejected by peer-reviewed medical journals who refused to publish their manuscripts. Today, of course, ICDs are in widespread routine use and have saved many lives. In 2002, both were inducted into the National Inventors Hall of Fame, and in 2005, Baltimore's Sinai Hospital named a medical building after Dr. Mower. So, just recently, past about 5 months ago, I gave a lecture to Tulane medical students in New Orleans. And I wanted to tell them this particular story because it involved a Tulane professor that I'm sure probably they never heard about. And that professor was Dr. Robert Heath. He was head of Tulane's Psychiatry and Neurology Department from 1949 to 1980. And so he was still there when I was there at LSU in graduate school and medicine. He was a brilliant pioneer and inventor of deep brain stimulation in 1951, especially pleasure center stimulation in humans. So he set out to cure a number of mental disorders, including schizophrenia, depression, and men who had unwanted homosexual urges. This was several years before the first psychotropic drugs became available. In 1950, the most popular psychiatric treatments were electroconvulsive therapy, ECT, and lobotomy, and of course, lifetime commitment to insane asylums. The technology that he invented and his experiments are among the most controversial experiments in U.S. history. It was met with great skepticism and criticism from colleagues and by neurosurgeons who said it was not a good idea to rummage around in the brain like that in schizophrenics, and was referred to by some as extreme black magic and unethical. It was also alleged at the time that his experiments were part of the MK Ultra project, which was the CIA's notorious mind control project. And MK Ultra, in fact, was the subject of a Senate hearing on August 3rd, 1977. And in 1978, a young Tulane law student actually interviewed Dr. Heath about this and the CIA connection, and published it in the student newspaper, the Tulane Hullabaloo. One study that did ultimately get published in the Journal of Behavioral Therapy and Experimental Psychiatry in 1972 involved a 24-year-old man, referred to as patient B19, who had attempted to commit suicide several times and who wanted to be cured of his unwanted homosexual urges. At the time, the Diagnostics and Statistics Manual of Mental Disorders, the DSM, which is still used today, listed homosexuality as a disorder. The study was performed in Charity Hospital over a number of months. And what Dr. Heath did was, he implanted an electrode in the man's pleasure center. And a prostitute was hired from the French Quarter for a monitored 2-hour session. Interestingly, the New Orleans district attorney at the time not only gave permission for this experiment, but actually helped procure the woman who participated. Okay, so that was the district attorney. The pleasure center stimulation was given at strategic points during the encounter with the prostitute. This experiment was not pleasing, of course, to the Catholic nuns who ran Charity Hospital at the time, because this was going on in their hospital. Tulane reportedly has films of this experiment, but will not release them to the public, but his son found the videotapes in his father's home office after his death and converted them to DVDs. And no, I'm not going to show them today, and provided them to the author of the book called The Pleasure Shock. So you're wondering, well, what were the results of this? Well, the man had a very positive response during the experiment, and after leaving the hospital had a long-term relationship with a woman. However, it didn't last, and ultimately there was no permanent change in his sexual interests. But note that there were no implantable pulse generators at the time, such as we have today, so long-term stimulation could not be done. And so all this is covered in a book called The Pleasure Shock, The Rise of Deep Brain Stimulation and Its Forgotten Inventor. And here's some of the neuroanatomy of it, in case you're interested. Probably you're not, but the nucleus accumbens, which you see anteriorly there, is the pleasure center. And you might notice that there's a bundle of fibers that go to that called the medial forebrain bundle. The nucleus accumbens is not real accessible. It's not in an accessible area, but the medial forebrain bundle, particularly as it traverses the hypothalamus, is fairly accessible to electrodes, for instance. So, I'm going to share with you some of my experiences with this. 53 years ago, while in college, I performed my first pleasure center implant in rats, 53 years ago. I continued to perform pleasure center implants in rats in graduate school for 6 years as a means of studying motor function. So this was not the focus of my research. That is, pleasure center stimulation was not the focus of my research. I just used it as a means to get the animal to make movements so I could learn more about the brain mechanisms involved in movement. In particular, I was studying the substantia nigra, which, as you all know, is one of the nuclei that's involved with Parkinson's disease. And so what I'm going to be showing you in just a short while here is a video of what this actually looks like. And I will tell you a number of things. Number one, these rats can be trained to obey verbal commands as far as when to start pressing the bar. So I can record, for example, from the brain during a quiet period, ask the rat to start pushing the bar and see, what neurons are activated. Now, the type of recording that I was doing was called single unit recording, which means I was recording the electrical activity of single neurons. So I could study a number of those while this was going on. The other thing I will tell you is that this type of research absolutely requires that the rat be extremely restrained. And ordinarily, rats don't like to be restrained, and you'll see what kind of a restraining cage that was used, and that's not something they necessarily like. But as you will see, this particular rat, one of the rats I used, knew that if he got in that restraining cage a short while later, he was going to get that pleasure center stimulation. So you will see this rat climb into the restraining cage on his own. And the other thing that I will tell you is, well, of course, you may remember from your college psychology days that there's classical conditioning, which was developed by physiologist Ivan Pavlov, and there's operant conditioning, which was developed by a psychologist, B.F. Skinner. The type of conditioning you see here is operant conditioning. The other thing I will tell you is, back in the olden days, 53 years ago, well, it was a little more recent than that, but we didn't have all the computers and whatnot to run these experiments. So I had to make a lot of the equipment. They're called logic circuits. I had to make a lot of the equipment to run these experiments. So without going into a little further, I'm going to show that I'm going to have Jeremy lower the lights so you can see this. Because I had the video converted to DVD a number of years ago, but the video faded, so it's not as bright as we'd like it. So this is a technique for recording single unit activity in an unanesthetized restrained rat. And so here you see the rat. There's the restraining cage next to his cage. He's kind of looking around. He says, "Oh yeah, well, I know what this is about. I'm just going to climb up and go right in that thing," and that's exactly what the rat does. And of course, they have to be very restrained, particularly their head. There he goes. Particularly their head, because the head has to be restrained in what's called a stereotaxic device, so that you've got X, Y, and Z coordinates to be able to place that electrode precisely. And I made all the equipment for this. This was a plexiglass headpiece. And so when you take that off, you have direct access to the brain. And by the way, when you insert these electrodes in the brain, there's no pain. Okay, so there's no pain receptors in the brain itself. And so you notice the rat's just holding very still while I'm unscrewing these very tiny screws that hold on the cap of the plexiglass headpiece. I mean, it's amazing. I mean, rats just don't ordinarily tolerate that kind of restraint, but he knows what's coming and likes it very much. So, then we'll go forward here a little bit. And I also designed a new type of microelectrode to use in these studies so as to increase the signal-to-noise ratio. So I developed a special concentric microelectrode to do that, and made them myself in the lab. So that was part of the equipment that was needed and ended up having to make it. And there's the bar. I made this bar that hooks onto the plexiglass headpiece. That bar is then used to accomplish total head restraint in the stereotaxic device. So I had XYZ coordinates to the exact nuclei that I wanted to go to. So here the rat is pressing the bar. Every time the rat presses the bar, he gets a train of stimuli in the medial forebrain bundle, which goes to the nucleus accumbens. And again, the rat can be trained. They're a lot smarter than you think. They can be trained to, stop and then start pressing the bar again when you tell them. And that's just it's a good way to look at the activity in certain neurons when things are quiet, and to look at it right before the movement is initiated. So this is a top-down look. That's the stereotaxic frame you can see. And in just a second, you'll see the microelectrode. And of course, this whole apparatus is all within a Faraday cage, which is also a necessity. And the experiment, each episode might go on for about an hour. There's the microelectrode. And again, that is advanced in a very careful way using the parameters on the stereotaxic device. There's some of the equipment that was used in doing this. And again, the equipment that was actually used to run the experiment I made. They were called logic circuits. So. Okay, put the lights back up. Decades after Heath's experiments, deep brain stimulation has been a major advancement in treatment of neurological and psychiatric conditions. But again, it was not well received by his colleagues at the time. Deep brain stimulation is currently approved for Parkinson's disease, and it's been of considerable benefit, where the electrodes are implanted in the globus pallidus internus or subthalamic nucleus. It's also been used with essential tremor, dyskinesia, treatment of a refractory OCD, and treatment of refractory depression. And you will see under treatment of refractory depression, one of the places that they place the electrode is in the medial forebrain bundle, because that goes forward then to the nucleus accumbens. And deep brain stimulation is currently under study for treatment of addiction, autism, anorexia nervosa, anxiety disorders, and schizophrenia. But today, current researchers are quick to take full credit for these new developments involving deep brain stimulation. New is in quotes. And when asked, they typically state that they never heard of Dr. Robert Heath or the experiments and treatments he proposed decades before their, quote, breakthrough discoveries, unquote. So this all got buried in the sands of time and was basically forgotten. So conclusions: censorship, suppression, ridicule, placing political correctness above science, and sham peer review harm innovation and advancement in medicine. Clinical guidelines and protocols have largely replaced clinical judgment and critical thinking. Too often, guidelines and protocols are misrepresented as the standard of care. I see this all the time in sham peer review. You didn't follow the guidelines, you're practicing below the standard of care. Out you go. This corruption of medicine has been promoted by the government and by expansion of so-called physician extenders and by corporate medicine. CMS guideline-based metrics, merit-based incentive programs, the MIPS also, which impacts physician payment. The vast majority of medical schools receive government funding, of course, based on compliance with and adherence to guidelines and protocols, again, misrepresented as quality improvement initiatives. Physician assistants and nurse practitioners who lack the training and experience of physicians predictably gravitate toward rigid adherence to clinical practice guidelines and protocols. But again, if you deviate from clinical guidelines and protocols, there can be severe consequences, including revocation of hospital privileges, and report to the National Practitioner Data Bank, and end of career. And number 4, lack of clinical judgment and critical thinking can lead to patient harm. Stifling innovation causes patients to be deprived of new treatments which may be beneficial to them. And with that, I will stop.